Welcome to the American Society of Echocardiography E3 lecture series. My name is Lucy Safi and I am Director of Interventional Echocardiography at Hackensack University Medical Center and Chair of the ASE Emerging Echo Enthusiasts, also known as E3 Special Interest Group. Today's Special Interest Group provides an opportunity for early career physicians, sonographers, and trainees who are interested in echocardiography to present, interact, and discuss echocardiographic topics. Each lecture is formatted as a 30-minute didactic lecture followed by a panel discussion. On the panel will be 2 moderators and an expert in the field. During the discussion section, the panelists will also answer audience questions, so please enter your questions in the Q&A box below. This virtual lecture series will be recorded and later available online at the ASE E3 website. To join ASE E3 Special Interest Group, log into your ASE account and under Update My Profile, click Specialty Interest Groups and then E3. Today's topic will be point-of-care ultrasound, also called POCUS. It is my pleasure to introduce my co-moderator, Dr. Marcelo Miglioranza. Dr. Miglioranza is professor of the postgraduate program of cardiology at Institute of Cardiology, University Foundation of Cardiology in Porto Alegre, Brazil. He also serves as a coordinator of the Echo Lab in Mãe de Deus Hospital in Porto Alegre, Brazil. He is the leader of the Cardiovascular Imaging Research and Innovation Group at his institution and is also a member of the second cohort of the ASE Leadership Academy. Thank you for joining me today as a co-moderator. Our physician expert today is Dr. Amer Johri. Dr. Johri has completed his advanced echo fellowship at Massachusetts General Hospital and went on to be founder of the Cardiovascular Imaging Network at Queen's University in Ontario, Canada. He served on multiple ASE committees and was chair of the ASE Statement on POCUS during the COVID-19 pandemic. Dr. Johri is also used to the stage as he gives the American Society of Echo Summer Weekly podcast for JACE Journal. Welcome to the podcast. It's an honor to have you here today.
Thank you.
Our guest speaker is Dr. Faloye. Dr. Bola is an assistant professor of cardiothoracic anesthesiology at Emory University in Atlanta. She is fellowship trained in adult cardiothoracic anesthesiology and board certified in advanced perioperative transesophageal echo. Dr. Faloye is also a member of the second cohort of the ASE Leadership Academy and serves as a member of the ASE Foundation. Welcome, Dr. Faloye. We look forward to your presentation.
Thank you very much, Dr. Safi, for that wonderful introduction. And thank you all for joining us here tonight. Good evening, everyone. My name is Bola Faloye. I am an assistant professor in the Division of Cardiothoracic Anesthesiology at Emory University in Atlanta. It is my pleasure to join you here tonight to talk about point-of-care ultrasound, also known as POCUS. At the end of this activity, I hope that learners are able to describe focused cardiac ultrasound findings associated with decreased ventricular systolic function, and also do the same for hypovolemia, pericardial effusion, cardiac tamponade, and some left-sided valvular lesions, mitral and aortic stenosis. I have no financial interest to disclose. I would like to start by acknowledging that many of the videos and pictures in this talk are courtesy of Dr. Amer and his team, who is my expert panelist here tonight, and Josh Zimmerman and his team at the University of Utah Perioperative Echo Service. So during this talk, I will cover some context for POCUS, also cover things about image acquisition, and lastly, follow up with some pathology. So let's get started by establishing the same mental model for everyone listening. POCUS is typically refers to a point-of-care ultrasound. However, it is an umbrella term, which covers a variety of organ systems, including lungs, cardiac, pulmonary, airway, and gastric. Now, we can spend an hour long on each part of this organ system specifically. However, in the time that we have tonight, I'm just going to focus on cardiac POCUS. So point-of-care cardiac ultrasound focuses on eliminating or confirming diagnosis based on a suspicion. Assessment is typically grossly qualitative, and quantification is optional. Images may or may not be archived by the practitioner. A clear advantage of POCUS is timeliness, as rapid diagnosis typically allows for prompt initiation of therapies. However, whenever you come across incidental findings, it is important that the patient be referred for a complete transthoracic examination for proper quantification, documentation, and follow-up. So who does POCUS? POCUS has played a role in nearly all medical subspecialties. It has dramatically expanded in areas of emergency medicine, critical care, perioperative medicine, and primary care. And of course, it was a go-to method for rapid assessment in the COVID-19 pandemic. POCUS is typically conducted by the treating provider to obtain real-time information for management decisions. The extent of the interrogation that is done depends on the skill level and the training level of the practitioner. There is no single unifying protocol across disciplines. This standards paper that was released by the ASE defines 4 main forms of cardiac ultrasound, of transthoracic cardiac ultrasound. It describes ultrasound-assisted physical examination, cardiac point of care ultrasound, critical care echocardiography, and the standard transthoracic echocardiogram, which may be limited or complete, but it's typically performed by staff from the echocardiography laboratory. Now, this discussion is a foundation. I talk about cardiac POCUS and refer to 2D findings mostly. There's a little bit of color Doppler sprinkled in, but there are people who believe that color Doppler does not belong to POCUS. What I don't talk about is spectral Doppler, which is clearly outside the bounds of POCUS, and it should be done by cardiologists or advanced echocardiographers who have sufficient knowledge. So cardiac POCUS typically focuses on answering dichotomous questions, appending a very loose qualitative description to severity. The diagnoses that are covered talks about the presence or absence of things like pericardial disease. Is there an effusion or is there not? What is the ventricular function? Is it normal or is it abnormal? Are there gross regional wall motion abnormalities? When we talk about regional wall motion abnormalities, we're not talking about the subtle ones. The ones you can see across the room are typically pretty obvious. Are there gross valvular abnormalities? We don't append any level of severity or quantification of severity to this. And then things like, is the heart full or empty? Now, for novice learners, the selection of ultrasound probes can be confusing. Briefly, probes are characterized by the frequency of waves that they emit and the footprint of the probe. The phased array probe is typically used for cardiac transthoracic ultrasound and also for POCUS. It has a low frequency, it's a low frequency probe, and it has a small footprint, which allows it to fit in between the ribs. Recently, portable personal ultrasounds have flooded the market, and these probes have really made ultrasound accessible to both experts and novices. So very quickly, I'm going to go over some probe movements for novice learners in the group. When we talk about movement of the probe, we refer to movement in the linear axis, translation, or rather slide in motion from one end to the other. Rocking refers to movement in the direction of the index marker, either towards it or away from it. Tilting or angling changes the cross section of the view you are looking at in the anterior to posterior direction. And rotation of the probe involves moving along the clock face, either clockwise or counterclockwise. Now, when it comes to nomenclature, there are typically 3 windows that we look through and 5 views: the parasternal window, the subcostal window, and the apical window. And the 5 views that are typically referred to in POCUS, sometimes 4 views, are the parasternal long axis, parasternal short axis, apical 4-chamber, subcostal 4-chamber, and the subcostal IVC. This may be substituted for the internal jugular long axis for volume assessment in patients. Now, the heart lies obliquely in the chest, surrounded by ribs. Optimal positioning typically is in the left lateral decubitus position with the arm abducted, the left arm abducted and the hand placed behind the head. This does 2 things. It opens up the inner spaces, allowing for a larger window for probe placement. It also helps the heart fall towards the chest wall. If you can't get your patient into a left lateral decubitus position, oftentimes a bump behind the right side could still improve your viewing windows significantly. So now let's focus on the 5 cardiac POCUS views. The parasternal long axis view is typically obtained with a probe in the left lateral sternal border with the index marker pointed towards 11 o'clock or the right shoulder. Typically, we're in the 3rd or 4th intercostal space. When you look at the parasternal long axis view at the top of the image, you have the right ventricular outflow tract, followed by the interventricular septum, the LV, the posterior wall of the LV, the mitral valve, the aortic valve, the aortic root over here. Assessment of this view should always be done in a routine manner every time. Qualitatively, the size of the RVOT is compared to the size of the ascending aorta and the root, or rather the root and the left atrium. The 3 should be about the same size. The structure and opening of the aortic valve should be assessed. The aortic valve should be thin leaflet. You should have thin leaflets here, and it should open completely and close completely with a coaptation point in the middle of the aortic root. Similarly, the opening of the mitral valve should be such that the anterior leaflet of the mitral valve opens briskly during diastole, and it almost hits or sometimes hits the interventricular septum and comes together completely, closes during systole. You should also note that there is a long coaptation length formed by the anterior leaflet of the mitral valve and the posterior leaflet of the mitral valve. In addition to this, you should have motion of the heart from the base towards the apex, briskly in systole, and movement in the anterior posterior direction of the aortic root. Now, when it comes to the size of the left atrium, that's typically important information. And as I alluded to earlier, you want to compare the size, the anterior posterior diameter of the left atrium to that of the aortic root and to the RVOT. Grossly, they should be about the same size. Now let's move on to the parasternal short axis view. This is still obtained at the left lateral sternal border in the 3rd or 4th intercostal space with the index marker pointed towards 2 o'clock or the left shoulder. Now the parasternal short axis view provides a wealth of information. As the probe is tilted from the base to the apex of the heart, we see the cross-sectional levels at the aortic valve level, the mitral valve level, papillary muscle level, and the apical level. Now, you may not need to image all of these structures, as the images you seek during POCUS typically depends on what question you are looking to answer. The go-to view for questions about volume status, global function, regional wall motion abnormality is the mid-papillary level. The parasternal short axis mid-papillary level transects the LV and the RV in the mid portion. The left side of the screen, you have the crescent-shaped RV followed by the interventricular septum and the donut-shaped LV. Typically, the interventricular septum should be concave towards the LV. This view also shows 6 segments of the LV, which represents the 3 perfusion territories of the 3 coronary arteries. Now, the size, or rather the movement of the interventricular septum should be noticed, as this gives you a clue to the difference between the RV pressures and the LV pressures. When there are no regional wall motion abnormalities, you should have symmetric thickening of all segments of the LV, endocardial excursion towards the middle of the ventricle, and this should all be synchronous. Now, when you have changes in the shape of the interventricular septum, it typically tells you that there is a problem with either RV or pressure or volume overload. Let's move on to the apical 4-chamber view. Now, this image is, this window may be the most challenging. Compared to the parasternal and the subcostal windows, this may be challenging for novice learners. The first step is to identify the correct window, and this may involve a little bit of window shopping. In some cases, you may choose to palpate the point of maximal impulse and place the probe in order to find the apex. The apex typically is inferior or lateral to the nipple in men and in the inferior lateral quadrant of the left breast in women. To get this view, I typically start in the mid-clavicular line, find an inner space that is slightly inferior to the nipple, and move the probe towards the anterior or mid-axillary line until I find the apex. The index marker typically will be between 3 o'clock and 5 o'clock. Now, when obtaining this view, it's important not to foreshorten, which results in the true apex not being seen. The apical four-chamber view allows comparison of the relative sizes of the RV to the LV and the atrium. The shape and the length of the RV should be noted in this view. Typically, the RV is triangular shape, and its length does not exceed about 2/3 of the length of the LV, and it certainly should not make up the apex of the left ventricle. Both atria should be roughly the same size in this view. Optimal subcostal views are obtained with a patient in a supine position. Patients who have thick abdominal walls, you may improve their viewer windows by having the patient bend their knees in order to decrease the abdominal wall tension. To obtain this view, I typically start just inferior to the xiphoid process, 1 to 2 centimeters to the right off midline with the index marker pointed towards 3 o'clock. Application of firm pressure is typically needed to bring the heart into view. The subcostal four-chamber view is an excellent view to assess global RV systolic function and cavity size. It's also an excellent view to assess the presence of a pericardial effusion, which will appear as an echolucent area. Now, at the top of this image, we have the gray structure, which is the liver, followed by the right ventricle, which you can appreciate as a triangular shaped structure, the interventricular septum, the left ventricle, the tricuspid valve separating the right atrium, and the left atrium separating the left atrium and the mitral valve separating the left ventricle. Now, when it comes to the subcostal IVC, typically you would start from the subcostal four-chamber view and rotate the probe about 90 degrees counterclockwise until the index marker is pointed towards the ceiling. This helps bring the IVC long axis into view. At the top of the image is the liver, and you have a near horizontal IVC in this image. Over here, you have the left hepatic vein draining into the IVC as both come together and empty into the right atrium. It is very important to distinguish the IVC from the descending aorta or the abdominal aorta in this image, which is shown as a still image here. The two are kind of close together. Now, the aorta is thick-walled, and you will often notice some pulsatility in the aorta, whereas the IVC is thin-walled, typically is intrahepatic. You will find some veins draining into it, and if you follow closely, it should empty into the right atrium. The utility of this view is that it helps in the assessment of the relative size and behavior of the IVC to aid in assessment of intravascular volume status in patients. Now, let's focus on some pathology. In the assessment of pathology, it is good practice to obtain more than one view of the same structure in order to confirm your pathological findings. Now, we're going to take a look at left ventricular global function, regional wall motion abnormality, right ventricular size and function, left ventricular wall thickness, left-sided valvular lesions, effusions, tamponade, and volume status. In the next few slides, remember the goal is qualitative assessment, normal versus abnormal, really bad or not so bad. I have not quantified severity in any of these images. Now let's get started. The assessment of left ventricular global function typically starts with either the parasternal long axis view, short axis view, or the apical four-chamber. All right. The parasternal, apical, subcostal windows all provide views through which systolic function can be assessed. I typically start in the parasternal long axis view. Assessment of LV systolic function examines endocardial excursion towards the middle of the LV cavity, myocardial wall thickening, and also movement of the base of the heart towards the apex, and movements of the ascending aorta or the aortic root in the anterior posterior direction. Now we're going to compare that to panel B, which again, let's look for endocardial excursion, myocardial wall thickening, movement of the base of the heart towards the apex, and movement of the aortic root. This is clearly depressed. Now, when we look at the peristernal short axis view, we pretty much go through the same process of looking for endocardial excursion towards the middle of the LV cavity and myocardial wall thickening. We'll compare panel C to panel D, which shows you the difference between normal versus depressed. Okay, let's look at the apical 4-chamber view. Now, it's important not to get thrown off when you have a bradycardic patient. Some of this video loops are deliberately slow. When you look at the apical 4-chamber view, what you need to look for is the movement of the base of the heart towards the apex, and also endocardial excursion towards the middle of the ventricle and myocardial wall thickening. The RV function can also be assessed readily in this view by looking for that base moving vigorously towards the apex of the heart and the cardial excursion towards the middle. Now let's compare panel A to panel B, and you can clearly see that panel A is normal, panel C is depressed. Okay, now regional wall motion abnormalities. In POCUS, the identification of obvious regional wall motion abnormality, not subtle ones, is what we do. The subtle ones we leave to the cardiologist, okay? If you can see it from across the room, it is significant. My go-to view for this is the peristernal short axis view. When you look at the peristernal short axis view, what you need to do is place a mental finger in the middle of the ventricle and look at all 6 segments, look for endocardial excursion that is synchronized, myocardial wall thickening that is synchronized, all moving in synchrony towards your finger. Now let's compare panel A to panel B, and you can clearly see that there's at least one LV segment that is more vigorous than the others. This is an obvious regional wall motion abnormality. Now let's switch gears and talk about right ventricular size and function. Go-to views are the apical 4-chamber view and the subcostal 4-chamber view. Now, in the apical 4-chamber view, I also have in panel A here, a normal looking RV and a normal looking LV. I pay attention to the shape and the size of the RV. You should have a triangular shaped RV that should not exceed more than about 2/3 the length of your LV. You should have vigorous translation of motion from the base of the heart towards the apex. You can see an excursion going on. Now, I'm going to compare that. Compare the size of the RV to the LV. You can clearly see that the RV is smaller. Now compare that to panel B over here, where there's no mistake in this. This is an enlarged right atrium and an enlarged right ventricle. Compare the size of the right ventricle to that of the LV. This is clearly dilated. The subcostal 4-chamber view may be a little bit difficult for novice users to pick out the RV to start. So let's walk through this very carefully. At the top of the image is the liver, followed by this echolucent area here. This is the RV, comes first, the interventricular septum, and then the LV. Even in this view, the RV should appear smaller than the LV. This is a normal view, even though it's a poor video. Now let's look at the subcostal 4-chamber view of the dilated RV. Again, we have the liver, we have the right ventricle over here. Compare that to the left ventricle. You can clearly see that this is dilated. Now, in RV dilation, typically what you worry about the most is massive pulmonary embolus, especially if the clinical picture fits. In patients who have significant hemodynamically significant pulmonary embolus, the left ventricle can appear underfilled and hyperdynamic. The presence of RV dilation and maybe a decrease in the RV systolic function should warn you that you need prompt intervention in these cases. Now let's take a look at some left-sided valvular abnormalities. I have picked 3 abnormalities that are most likely to impact medical management in acute or emergent settings. Not all of them, just aortic valve stenosis, mitral valve stenosis, and severe mitral regurgitation. So let's focus on panel A first. This is the peristernal long axis view showing the aortic valve in zoom. What you want to pay attention to is the width of the leaflets of the aortic valve, the cusps of the aortic valve. You want to make sure that they're thin. not thickened, not especially calcified. You also want to pay attention to the motion of the leaflet as it opens. It should open completely and come in close approximation with the aortic root when it does that, with the wall of the aortic root when it does that. When it closes, it should close with a coaptation point that is in the center of the aortic root, and you shouldn't see a coaptation defect. Now, forgive me if you're not used to color Doppler, but I have a little bit sprinkled in here, just to show qualitatively speaking. When you put color Doppler over the aortic valve, this is what laminar flow looks like. You don't have any turbulence, which is normal. This is indicative of laminar flow, no flow acceleration. Now, turn your attention to panel B, which shows, again, the peristernal long axis with the aortic valve in zoom. Notice the heavy calcification of the aortic root. Notice the aortic valve cusps over here. They're both calcified. And note that there is barely any leaflet or cusp separation. There's a thin echolucent area during systole that you see here for the blood to eke through. Now, you can put some color Doppler on it and you can clearly see some turbulence. All of this beautiful rainbow-like color that forms is turbulent flow as it passes through the aortic valve. This is aortic valve stenosis. If the clinical picture fits, if the patient is hemodynamically significantly affected, this might be the reason why. I'm not going to give severity to this. I don't have enough images or spectral Doppler. I am not going to quantify the severity. Is it bad? Probably if the patient is symptomatic. Okay, now let's take a look at the mitral valve. This is the peristernal long axis view of a normal mitral valve, also in zoom. When you look at the mitral valve, you also want to make sure that the leaflets are thin, not thickened. And you want to note the motion of it as it opens during diastole. Note the anterior leaflet of the mitral valve here as it opens completely, almost touching the interventricular septum. In some patients, it'll actually touch. Now, watch it as it closes completely and it meets the posterior leaflet of the mitral valve over here. You clearly see a little bit of a coaptation length over here. This is normal. Now, let's compare that to panel B. In panel B, you can clearly see a deformity of the anterior leaflet of the mitral valve as it opens. This deformity kind of looks like a hockey stick. Yes, it is called a hockey stick. This is pathognomonic for rheumatic mitral stenosis. I also want you to pay attention to how much leaflet separation you see here. Very little. This compared to this is kind of significantly narrowed. Now, this is not especially calcified. It's not especially not too thick. It's a little bit thin, but clearly the space that you see between the leaflets when they open here seems to be a problem. Now, supporting findings on ultrasound to support the diagnosis of mitral stenosis. Let's come to the size of your left atrium. Now, remember I said qualitatively speaking, you have to compare the size of the left atrium to that of the aortic root to the RVOT. Now look at all three, the left atrium is enlarged. Okay, so now you've got two signs. You've got this mitral valve that's not opening very well and an enlarged left atrium, which supports diagnosis of mitral stenosis. Now let's take a look at the apical four-chamber view. As the anterior leaflet of the mitral valve opens, again, you should see it come into close approximation with the interventricular septum. It should come back together with the posterior leaflet as it closes. Now, this is normal. Now, one thing that I failed to mention earlier is you shouldn't find anything flicking back into the left atrium here. If you see anything moving across we'll call it the annular plane, that's typically a sign of either a flail valve leaflet or mitral valve prolapse. You may see the same thing in your four-chamber view. Now let's compare panel C to panel D. Pay attention to that mitral valve over there. You can barely see any movement. It doesn't really swing open against the interventricular septum. It kind of seems like it's stuck in there, okay? All right. Now, in the United States, there are typically two reasons why you'd have mitral stenosis, either calcific mitral stenosis or rheumatic mitral stenosis. This is an example of calcific mitral stenosis. We look at the mitral valve, again, in peristernal long axis, zoomed in. We see calcification of the leaflets and barely any leaflet separation during diastole. Let's hop over to panel B over here. Again, you see calcification of both leaflets and including the aortic valve over here. But notice that this valve seems to open a little bit better than this one does. Is it moderate? Is it severe? I'm not going to do that, okay? We still have mitral stenosis. All right, so mitral regurgitation. Now, this can be very important when you have a patient who presents in pulmonary edema. If you've got a patient who presents in pulmonary edema and you suspect that the problem is the heart, you put an ultrasound probe on, you see this pattern, there's a problem. So take a look again, peristernal long axis view. I want you to pay attention to the anterior leaflet of the mitral valve as it comes together with the posterior leaflet of the mitral valve over here. You can see a clear coaptation defect. Okay, those two don't come together and you don't see that seemingly redundant coaptation length that we saw in the normal view. Now I'll put a little bit of collar Doppler on it, and this is rip-roaring mitral regurgitation. There's flow back into the left atrium. Also in the apical 4-chamber view, you note the clear coaptation defect over there, put a little bit of collar Doppler on it and see the flow back into the left atrium during systole. Now let's talk effusions. When it comes to effusions, typically, if you put your probe and you get the peristernal long axis view, you may find something interesting. So when you do a peristernal long axis view and you see an effusion, the first thing that I would say is look for your ascending, or rather your descending thoracic aorta, because all effusions that are anterior to it are pericardial effusions and posterior to it are typically pleural effusions, okay? A pleural effusion is an echolucent area. It appears dark on echo. Again, you see it here in the peristernal short axis view. Now, not all effusions cause tamponade. Tamponade is the clinical diagnosis. However, you may find supporting ultrasound findings. So let's take a look. The subcostal 4-chamber view is the go-to view if you're concerned about cardiac tamponade. Let's walk from the top of the screen. You have the liver, and you have an echolucent area around the heart. Now, the ultrasound diagnosis or the ultrasound finding in cardiac tamponade typically is inversion of one of these chambers. Here's the right atrium, what it should be, the right ventricle, and you can see it kind of swaying around and inverting as the heart fills and it empties. This ultrasound finding supports the diagnosis of cardiac tamponade. All right, so I have included the assessment of left ventricular wall thickness because it can lead to misdiagnosis in the assessment of LV volume during diastole especially. Now, a quick assessment of the interventricular septum compared to the posterior wall can be done very quickly. The posterior wall and the interventricular septum should be about the same width, but more importantly, the posterior wall here shouldn't be more than about 3 times the width of your posterior atrial wall. Now, I want you to compare panel A to panel B, and you can clearly see that there is hypertrophy of both the interventricular septum and the posterior wall over here. The panel C shows your peristernal short axis, which is normal. We compare that to the peristernal short axis over here, which is hypertrophied. Now, let's skip over to volume status. Now, when you want to figure out whether or not your patient is hypovolemic, that's the reason why they're in shock, you can look at the peristernal short axis and support that also with a subcostal IVC. Now, in hypovolemic states, the LV typically appears small. Let's start there. But when you assess the size of the cavity, it is important for you to do it both in diastole and in systole. But first, I would say start with your ventricular walls. Make sure you know whether or not it's thickened versus not thickened, as in hypertrophied. Then look at the size of the LV cavity during diastole. Is it smaller than it should be? During systole, typically, if the patient is hypovolemic, or if the patient has a high cardiac output state, you will find what is typically called a kissing papillary muscle, which is almost complete emptying of the LV, which is simply just a sign of a high cardiac output state. Now, we'll support that by looking at the subcostal IVC view. Here's the IVC. Typically in hypovolemic states, you should see almost complete collapse of the IVC during inspiration. All right, so we've kind of zipped through a lot, but we are at the end of this talk, of my section of the talk anyways. The ASE has several educational resources available free on its website. We've got the POCUS education model, which is easily accessible under the education tab. and a couple of expert consensus, which are also available. The POCUS journal, be on the lookout for this. The POCUS journal is a biannual peer-reviewed publication that contains the latest research and case reports and protocols. Our expert panelist here tonight is the founder of the POCUS journal. Now, I am at the end of my talk. Thank you very much for your attention, and we will open it up to the Q&A part of this talk.
Thank you so much, Bola. That was an excellent presentation. I really enjoyed your examples. I thought those were very educational. And I do want to ask my pleasure. It was wonderful. I wanted to ask you, Dr. Johri, I know that you have published a lot of on POCUS, specifically during the COVID-19 pandemic, where its use was very widespread. Can you talk a little bit about POCUS during the COVID-19 pandemic and how you saw changes and how you think these changes will continue to be used in the future?
Thank you so much, Lucy, for that question. First of all, Bola, I want to congratulate you on an excellent talk. That was very good. So thank you so much for doing that. It's one of the best POCUS talks that I've heard. So thank you for that. I wanted to mention that Bola was really quite concise and very pragmatic in her presentation, explaining why she remains within scope. And it's not because she's not able to, or she's not smart enough, or she's not skilled enough, but she's trying to get pictures quickly to answer the question. So I really liked how she said, this is where I stop because this is what's useful for me. And sometimes we don't hear that, where yes, POCUS can do everything, is the answer to everything, but really we need to look at the reality of what is the best for the patient, how you can get the question answered quickly at the bedside, how far you need to go. And so this was a very good message. And sometimes if you do need that spectral Doppler, sure, you have the cardiologist that can help you. You don't have to take it all on at the bedside with the limited technology you have. So I thought that was a wonderful principle that she brought up and really got real in terms of the clinical application. So the second thing I wanted to mention was I'm so honored to be here today, and you actually said this was an important topic. And that still brings a smile to my face because I started doing research in this area 11 years ago. And at that time, people were like, why are you presenting work in POCUS? What are you doing? Is it really an area that people are interested in? We even weren't sure whether to call it POCUS or FOCUS or handheld ultrasound or pocket echo. There's all kinds of different terminology. And I kind of pushed for the POCUS term. I thought that was the best term. So it's really nice to hear someone say, oh, this is an important topic. And I'm really honored to see how the topic has grown. And thank you, Bola, for presenting the POCUS journal. We started that 6 years ago, and the audience includes anesthesia, emergency, internal medicine, primary care, and even our allied healthcare practitioners who are also looking at the use of POCUS, especially for enhancing the physical examination. So this is wonderful, a wonderful opportunity. With respect to your specific question, how did POCUS come in with COVID-19? And this was really very serendipitous in that we had been working in the area of POCUS and we weren't sure exactly how prominent it would become. And then the pandemic happened. And then it just was sort of a kind of a marriage made in heaven, although it was, I would say it was a silver lining of a very dark cloud, right? So the pandemic was a dark cloud, but the silver lining was that we had been thinking about the utility of POCUS. And that was really the impetus for the ASE COVID-19 statement. And what we saw was that POCUS allowed us to reduce the use of PPE and also helped to more judiciously use echocardiography when we needed to, so sometimes guided by POCUS. And the advantage was it helped us to limit contagion in some situations. So we weren't necessarily having sonographers and machines going back and forth from the echo lab. The practitioner, now that they were becoming more skilled because of previous years of discussion, could also do a POCUS and decide what images were needed and how important that echo really was. And so that was the impetus for promoting the COVID-19 statement in POCUS. And that is available on the ASE website, and Bola did show a picture of that. And I wanted to mention that there have been some outcomes as well, some outcome study work that's been done looking at the use of POCUS in COVID-19 and the pandemic. And so if you go, for example, to the JACE website here, and if you hit multimedia and podcasts, it's thinking you should get a series of podcasts, and we quite often talk about POCUS in these podcasts. One of the podcasts that I want to bring your attention to was this special podcast looking at lung and cardiac POCUS during COVID-19 by Dr. Sazakili in the June issue. And it summarizes the predictive role of both combined cardiac and lung ultrasound in COVID-19. And so there are other POCUS podcasts as well, showing how workflow was improved during this time, and also showing some of the prognostic ability as well as the correlation to some outcomes. So in summary, I think POCUS is something that's here to stay and has been becoming more prominent because of the pandemic, specifically looking at cardiopulmonary symptoms. So although today Bola talked mostly about cardiac point of care ultrasound, lung POCUS is also very important. And kudos to the ASE because they allowed us to incorporate both cardiac and lung POCUS into the most recent statement. So as the ASE was going out of its comfort zone, incorporating lung ultrasound into cardiopulmonary POCUS, we're encouraging others to do so as well in this instance.
That's really great, and I really like the fact that you know, your podcast, which is wonderful by the way, is available both in the video version if you're at a computer, and also as an audio version. So for those of you that listen to podcasts on their commute, you know, it's very informative and very helpful. So really great. Thank you for sharing this with us. I know that Marcelo, you are on the line, you know, during a case. I know in Brazil, you know, care continues to go on. But, you know, I wanted to ask at your institution, you know, how often is POCUS done? Is it primarily in the ICU ER setting, or is it done in other locations?
So, sorry, I am here in surgery room for more than 3 hours in a single case that get some complications, but we are doing okay. So we started with POCUS in ER. Here we have a huge, fully dedicated cardiology emergency, and as we know, for long the most frequent complaint is dyspnea. So to perform a different diagnosis from cardiogenic and non-cardiogenic dyspnea, it makes completely different from the treatment of the patient. So we started to implement for our fellows and our residents a training to perform a focused cardiac and lung ultrasound in this type of patients. After that, we implemented in STEMI and acute coronary syndromes, and right now we are implementing in ICU tab. So it's a great program. Now our residents are learning how to perform POCUS, incorporate, and they to send some images for the staff of the Echo Lab when they have some doubts, and then we can discuss, and they could perform a rapid decision-making process to deliver the right treatment for these patients.
I think that's really great, incorporating it into their training and fellowship, and hopefully they carry that on when they're, independent practitioners. I mean, that's really, really great. And, Bola, I wanted to ask you the similar question, in cardiac anesthesiology, how do you use POCUS? Do you use it on a daily basis, or is it something that's rare for you?
So POCUS comes in very handy in our non-intubated patients, typically in the preoperative area if there is a complaint, or after hours if we've got a patient who's got a concerning symptom but needs to go to surgery. And of course, cardiology, it's after hours. Cardiology is not in-house. It comes in handy then. We also use it on the PACU area after anesthesia. If we have a patient who suddenly develops hypotension or shock symptoms for any reason, it's easy enough to put the ultrasound on them. And also off-site procedures. When we do off-site procedures, this comes in so handily. When we don't have our normal echo machine around, we have a non-intubated patient and we need rapid assessment. POCUS comes in very handy also, but typically only really in the perioperative arena.
So it can be used essentially everywhere. The consensus, it seems like, with all of our panelists, and it's really exciting because I see the future, and the future is just growing. And Dr. Johri, I wanted to ask, what are your thoughts on AI, and how do you think AI is going to make point of care ultrasound more useful?
That's a great question, Lucy. So definitely, I think AI is going to enhance the user experience, the end user experience. And so it'll help the people out in the field, and especially new users, to pick up these skills and become more proficient quicker. And so especially with some AI that guides treatment, and we've seen some vendor models already that have not quite yet been released, but actually guide the quality of the imaging. And at the bedside, the AI can sort of indicate whether there has been a good image obtained, or whether they need the user needs to move and slide or tilt or rotate to get a better image. So that there's that guidance. And then AI may also help with interpretation as well. And the advantage of AI is that it will look at features that we're used to seeing, but it may also consider other features that we're not used to seeing, that we may not know about, that signals that it picks up on that we can't necessarily see, but can integrate much more than a human can. So I think that's going to be really interesting and important. One of the things that I've been playing around with is what I call augmented intelligence. So it's a little bit different than artificial intelligence. It's actually human intelligence helping to guide remote users. And so what's interesting, you asked a technology question, so I want to give you a different technology answer. The era of tele-streaming and tele-POCUS and tele-mentoring is here now. And so especially here in Canada, we have many communities that are geographically remote and low resource. And what we've been trialing and showing is the ability for users out in these remote communities to live stream images to me while I'm sitting in the echo lab So I can provide human guidance. So can you slide your probe up, or can you rotate, or can you push harder? You need more gel at the time of scanning, providing both guidance and even interpretation. And this hub and spoke model is what we've developed across Canada. It's sort of a national network that was supported by the Canadian Cardiovascular Society. So I think that's where things might be moving towards, in addition to the AI that you mentioned, but these live stream technologies, especially for low resource areas, are going to come in quite handy, I believe, in the near future.
Yeah, they're definitely user friendly, and even novices with this AI technology are really able to get really nice, beautiful images of all the views that Bola described in our presentation. So I'm really excited to see, where AI takes us next, and I think it's definitely a great and growing field. We got a question from the audience by Bharat Patel, one of our local excellent sonographers here. And he wants to know from the panelists, how do you report your POCUS imaging findings? And do you use any kind of archiving platforms in order to save the images? So, Amer, why don't we start with you, and we can go around the panel.
Yeah, so I personally do not store my POCUS images. So I'm using POCUS. So I'm an echocardiographer, but when I'm on service on rounds, I use POCUS during my rounds, and I'm using it to enhance my physical examination. And at that time, I'm making a note in my physical examination section of my chart. So that's where I'm making a note of it. And for me, I'm happy with that because it's something that is nimble, quick, and I don't want to deal necessarily with archiving. As Bola mentioned, there isn't necessarily a standard. She, in her specific slide, she mentioned, quantification might be optional. And so, I think archiving can also be optional based on the workflow, because we don't want to necessarily restrict access. Now, there are people who are doing robust archiving. So for example, our emergency room physicians, they do the FAST exam, and they archive on a POCUS share service called QPath. And so also our anesthetists also archive their images there. And we're able to access those if we needed to in the echo lab as well. So there is some archiving occurring, and there are services available for that. And you really have to come together as a group to decide, do you have the resources for that? And, is this going to be the standard for all of your POCUS? Now, there may be another center that doesn't have the resources for archiving. So does that mean we say you can't do POCUS? Probably not, right? And so it's a question that's not fully determined whether you must have archiving or not, must have reporting or not. Personally, I think you can do POCUS and not archive and report if you're using it as a tool to enhance your physical exam.
Same question.
No, I totally agree with Amer. It's the most important is to describe your findings in your evolution, together with your physical examination, because the POCUS image gives you some important information for the decision-making process. And then when other physicians will evaluate this patient, they need to know how they make that decision. So that's important to describe. And have also some legal issues. But the images and the formal report, we don't need now.
Yeah, I totally agree with Amer and Marcelo. We also do not archive. Now, typically, if we have a novice who is acquiring images without an expert at the bedside, then we go ahead and we save those images, but we don't necessarily archive or report or write a formal report on those findings. We do make a note in the chart, typically in a progress notes section, to make a note of our findings, but we don't have any archiving system available currently.
So I will say at our institution, a majority of the handheld POCUS that we do in the ER and the critical care is not saved. However, during COVID, our handheld echoes were being able to be saved. And, you know, our handhelds were used by the sonographers just to minimize the amount of equipment that would be going in and out of the room. And that was actually archived in our echo reading database. But typically, the POCUS that is done usually is not saved and just supplementary to the physical exam, as all the other panelists have mentioned. So it is possible, but not usually at a day-to-day basis. At least that's my institution. So it was really great. I can't believe how fast the hour went. This was a very excellent discussion, and I wanted to thank all of the panelists. You know, I really appreciate the time, and you know, it's really an international panelists today. So I really appreciate you all joining in. I wanted to say that our next E3 lecture is going to be held on July 26th, and it's going to be the first of our series of structural heart, and it will be on left atrial appendage intervention. So I encourage you all to join our structural heart mini-series this summer in the E3 lecture series on July 26th. Thank you all for joining in. Have a great night.
Thank you. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye. Bye.